Right, good afternoon, everyone. Thank you very much for joining us to our Staying Connected webinar series during this COVID crisis. We are just trying to stay in contact with all our healthcare workers and just to give you some information on all our products and services. So today's webinar is going to be on delayed cord clamping and cord blood collection. I will go through a presentation with you, starting off with how to do a good cord blood collection, what is adequate volume and cell count, and why that is important. And then I have a little cord blood collection video to show you. Then we'll go on to the benefits of delayed cord clamping and to show you two studies to show that delayed cord clamping can be done with cord blood collection, and going through the international guidelines that exist today. So not a very long webinar, but certainly an interesting topic that very often comes up when parents are planning or doing their birth plan and trying to decide on the merits of cord blood collection or delayed cord clamping or both. So to start, let's discuss cord blood. Cord blood is a valuable source of hematopoietic stem cells for transplantation, and that is bone marrow transplantation. Hematopoietic stem cells are stem cells that generate the bone marrow in a person, and those are the stem cells that are needed when someone has a disease affecting their bone marrow and their bone marrow needs to be replaced. So scientists found that cord blood contains these valuable hematopoietic stem cells, and therefore it was proposed that one stores those at birth. And these cord blood hematopoietic stem cells are particularly valuable in pediatric patients requiring bone marrow transplantation. As time has gone on, certainly cord blood has been challenged by other stem cell sources, such as the donation of haploidentical bone marrow donors. Now, haploidentical bone marrow donors are essentially is a bone marrow donor, but with different regimens of chemotherapy, we can now give someone a bone marrow that is only half matched to the recipient. You do not need to have a full matched bone marrow. So obviously this has opened the door to many, many more donors and challenges cord blood's place as a great source of stem cells. Nevertheless, cord blood does have the advantage of requiring lower HLA requirements for tissue matching, and it is readily available. So cord blood is stored in cord blood banks. Should it be needed for a transplant, it can be easily accessed through a bank in a quick amount of time, usually 1 to 2 weeks. Whereas getting bone marrow from donors does take a bit longer. Now, what is important to make cord blood, a cord blood unit, clinically useful, is that we need a good volume of cord blood to be collected initially so that we can achieve an adequate number of cells for the transplant. So the mean collection volume around the world, and these are stats from all cord blood banks, is about 80 to 100 mils. So you can collect about 80 to 100 mils of cord blood from a single placenta. Now, this volume does also include the 29 mils of anticoagulant in the blood, so one must just be wary of that. This volume of cord blood is necessary to achieve the adequate cell count. The minimum dose of nucleated cells which are denoted by CD45 positive on flow cytometry, that are needed for a successful bone marrow transplant is about 10 to 20 million per kilogram. So a cord blood unit can have anything, anywhere between 100 million and 1.2 billion cells. And this number really does vary between cord blood units. There are many, many factors that influence the number of cells found in a cord blood unit, and that is why it is very important to test every single cord blood unit we get and analyze the number or record the number of total nucleated cells that are found in that cord blood donation. Excuse me. I am coughing, but I don't have COVID. I just want to show you a quick snippet of a video on cord blood collection and how to optimally get as much blood as possible. This video was filmed at the Netcare Park Lane Clinic, and here we go.
With the baby, get the assistant to clamp the cord about 5 centimeters from the umbilicus. Whilst this is being done, the surgeon must clamp both uterine angles and any major bleeding to limit blood loss while collecting the blood. The surgeon should then milk any excess blood in the cord towards the baby before the cord is cut. The surgeon then stabilizes the cord with the left hand whilst inserting the needle towards the placenta in the vein, preferably as close to the clamp as possible. As this is a sterile environment, it is not necessary to swab the cord during cesarean section at the insertion site. The assistant repeatedly, gently milks the cord towards the needle to speed up the collection. The cord in this patient is very tortuous and difficult to milk. Nevertheless, a good volume of blood is still attainable with the milking method. It is not necessary to hang the bag off the table. The lumen of the tubing is too small and too long to effect an efficient siphon mechanism. The milking of the cord exerts adequate pressure to fill the bag. If one is not sure whether enough blood has been collected, the needle can be inserted further upstream or into one of the arteries in the cord. Although these vessels are small, it will increase the collected volume slightly. Occasionally, the bleeding from the uterus is too much despite clamping, and the procedure must be with the baby.
So that video showed obviously a cesarean section. Cord blood collection obviously also happens with vaginal deliveries, and the same procedure can be followed. I just wanted to stress that the bags do not have any suction on the bag. That they're simple blood bags, and the blood will purely flow into the bag. If blood stops flowing, do remember that you can take the needle out and reinsert it further up into the cord. And a good collection, like you see on the screen here, is one where I would say the bag is just over half full with thick red blood. If it is very watery, or a light red color, it's unlikely we'll get a good cell count. Nevertheless, we test every single unit regardless. So another thing I wanted to mention, and many doctors have asked me in the past, why are these bags not labeled with a milliliter scale so that we know how much blood is collected? Unfortunately, this is something we have been asking for many years, but the manufacturers of these bags cannot accurately label volume on them, and therefore we just really have to eyeball it and try and get as much blood as possible. Obviously, we do say in our meetings with the patient that the mother and child are and their health is is more important than the collection of cord blood. And if for whatever reason cord blood collection has to be abandoned, then so be it, to preserve the mother's health and that of the child. Right, next slide. I do want to say, if you have any questions, please pose them in the question box. You're welcome to do that during the presentation, and then at the end I will address all your questions. Right, so moving on to the benefits of delayed cord clamping. So there is no physiological rationale really for clamping the umbilical cord immediately after birth, although it was previously thought to be an important part of active management of the third stage of labour. However, these ideas have subsequently changed. And in your moderate to late preterm infants, delayed cord clamping has been shown to reduce the need for transfusion, lead to circulatory stability, improve blood pressure, and decrease the odds of ventricular hemorrhage, late onset sepsis, and necrotizing enterocolitis. It has also been suggested that delayed cord clamping prevents low cardiac output state, increases right ventricular output and superior vena cava flow, protects vital organs, and avoids vigorous resuscitation, leading to the commencement of spontaneous breathing with better lung aeration and postnatal myocardial adaptation. So for your later, moderate and later preterm infants, there really are many, many advantages. And certainly studies have shown for your very prim neonates born at 28 weeks of gestation or earlier, that it really does reduce the incidence of hospital mortality and blood transfusion after delayed cord clamping. So I think the evidence is very much out there that delayed cord clamping is of benefit and really should be practiced. And so in 2011, when cord clamping really came to the fore, it was published that newborns were at increased risk of inferior iron status if subjected to early cord clamping practices, defined as 15 seconds or less after birth. So delayed clamping was defined as clamping the cord after 60 seconds after birth. The 2017 committee opinion of the American College of Obstetricians and Gynecologists recommends a delay of at least 30 to 60 seconds after birth. So how can a cord blood collection be achieved with delayed cord clamping, seeing that I have stressed that we really do need as much blood as possible? I have two studies here, two published articles that I'd like to show you, where they have shown successful cord blood collection with delayed cord clamping. The first was a study from the National Swedish Cord Blood Bank. Cord blood units were collected from two universities by trained nursing staff. Cord blood volume and the number of total nucleated cells were measured in 308 samples taken in 2012 and 2013. Delayed clamping was defined at 60 seconds post-birth. The results of the study showed that the volume collected after delayed clamping was definitely reduced by 8 to 10 milliliters on average. 60% of the units achieved the upper limit of the total nucleated count needed. And as they were a public bank, they were able to discard the other 40% of units as unsuitable for storage. Now, for a public bank, that works because they have no commitment, obviously, to the patient to keep the cord blood. However, in a private bank, we obviously do have a commitment to these people, and they have paid a certain amount of money. So perhaps delayed cord blood banking over 60 seconds may result in an unbankable unit. Nevertheless, in this study, their conclusion was that cord blood banking is feasible with delayed clamping practices. But if we look at our second study, which was conducted by the National Cord Blood Program of New York in 2018, they did an initial study of 552 women and indicated that, an initial study of 522 women indicated that delayed cord clamping of longer than 120 seconds decreased chances of obtaining a bankable unit significantly. The current study now that I will talk about was conducted on 1,210 women. They compared immediate clamping, defined as less than 30 seconds, and delayed clamping, defined at 30 seconds, 60 seconds, and 120 seconds post-birth. And what they found was there was a 10-fold decrease in total nucleated count when delayed cord clamping was over 60 seconds. Volume collected decreased to about 40 mils on average in patients that had 60 to 120 seconds of delayed cord clamping. So in the group that did delayed cord clamping for 30 to 60 seconds, there was an insignificant decrease in the average total nucleated cell count number, and the volume was only decreased by 10%. So the conclusion from this study is that delayed cord clamping of 30 to 60 seconds has a small negative impact on the collection of high total nucleated cell counts cord blood units. Increasing the delayed cord clamping to more than 60 seconds decreases significantly both the total nucleated cell count number and volume, much less chance of obtaining a clinically useful cord blood unit. And I think that is, certainly very important for us to take home. I have had discussions with some midwives that do their own deliveries, and they have successfully collected cord blood despite delaying cord clamping longer, than 60 seconds. In fact, doing it for a few minutes. Nevertheless, this is what the science shows, and I guess that is what we have to base our guidelines on. And after these studies, the following recommendations came out from the Canadian and American Obs and Gynae societies, saying that providing the mother is not iron deficient and that the pregnancy is at least 37 weeks gestation, cord clamping at 30 to 60 seconds after birth will ensure a safe outcome for the baby and yet allow for adequate umbilical cord blood collection if the parents wish to do so. And I think these are very sensible guidelines. Cord clamping is beneficial for the child, and over 37 weeks gestation, perhaps cord clamping at 30 to 60 seconds after birth is a good idea. And we must also remember that in bigger babies, a longer delay in cord clamping may lead to neonatal polycythemia and all its complications. That is just aside, but I think these are sensible guidelines, and certainly us at MedCells understand the value of delayed cord clamping and therefore have chosen to follow these guidelines. We counsel patients that wish to do extended delayed cord clamping that they may not be able to collect a clinically usable cord blood unit. And I do think it's important that the parents know that, and we're very happy to share the studies with them. after a cord blood unit has been collected, each unit is analyzed for volume and total nucleated cell counts. And if the counts and volume are suboptimal, in other words, they do not reach the number of that is adequate for a good bankable unit, we do notify the client, and they are counseled on the value of storing the unit or not. They are given the choice whether they want to continue or not. Should they not continue, we do refund their processing and storage fees. There is a non-refundable deposit that they pay initially of a couple of £1,000 that has to cover the kit and basically the collection procedure of the cord blood, but then they obviously do not pay for the rest, which is the majority of the payment. So that is our stance on delayed cord clamping, and I hope that you find this useful as a useful guideline in your practices, and that you are able to advise your parents. It's very important to have a birth plan, understand the pros and cons of everything in that birth plan, so that they can make sensible decisions and choices. So that really is the end of the webinar. Are there any questions? I see a question here. Sorry, let me try and get the question. Gosh, it's so difficult. What happens to suboptimal collection units, and what is communicated to the patient in this case? So, as I said, if it is a suboptimal unit, the patient is telephoned either by myself or the other medical officer to explain to them the number of cells. And we also then go through what that number of cells can actually do or can't do. The patient is obviously welcome to ask us questions. We then send them an email in writing explaining everything, so that they can do their own research and perhaps, ask their doctor or other people involved in the healthcare industry whether it is worth storing or not. And it's completely up to them. And they come back to us within about 2 weeks and decide. If they decide not to store, the cord blood unit is discarded. Are there any other questions? Am I not seeing them?
Yvonne, there's one other question. Do we always milk the cord, both in a C-section and normal birth?
Yes, I would milk the cord both in C-section and normal birth. Milking the cord often, if you can have an assistant to do that for you, because as the collector, you are holding the cord blood in one hand, the needle in the other. And if your assistant can just milk that cord down towards the needle, that is very, very helpful. And it will help with your very short cords and your smaller placentas. So yes, I would do it for both cesarean section and normal birth. Are there any other questions?
Yeah, there's another one. Do you always squeeze the anticoagulant into the bag? As you mentioned, optimal bags have 29 moles of anticoagulant.
Yes, so our bag, it has anticoagulant in the bag, but then there's the anticoagulant little pouch that you have to break to, it's basically to wash down the cord blood that is in the tubing. So Yes, if you could squeeze that into the bag and then just mix up the cord blood, just gently massage the bag so that the anticoagulant and blood all mix together.
Okay, then we've got another question. Can you clamp immediately, take the volume of stem cells needed, and then release the clamp for the rest of the blood to go into the baby?
I don't think so, unfortunately, because if you clamp, those clamps tend to really squash the vessels and tissues. And once you release the clamp, you may not you'll have too much damage of the umbilical cord, and the blood will probably not flow through. So I do think that, the delayed cord clamping has to be done first. Also, you have a lot of physiology going on in the baby. As the baby comes out of the womb, it takes its first breath, it starts developing the negative pressure in its chest. The vessels of the umbilicus start to constrict. Blood flow from the placenta into the baby starts decreasing. So if we want to effect delayed cord clamping properly, we have to allow that to happen in the first few seconds after birth. Really, that first minute is quite important. Then clamp and collect cord blood. And again, I stress this really is for your bigger babies. If you are delivering a 30-weeker, I do think delayed cord clamping takes preference to stem cell storage. And, I'm sure you would all advise your patients as such.
Great, thank you, Yvonne. Then there's another question that says, what is the possible reason for little to no blood at a collection?
Well, reasons, over the years is there's perhaps, the severe constriction of those umbilical vessels. So you may put the needle in and the blood just doesn't flow out. Obviously, if there is blockage in the tubing, if the tubing is clamped for whatever reason in the bag, one must always check the apparatus. But if all that is fine, there could be physiological reasons. There may not be a lot of blood, the cord may be very short, there's not enough pressure from the placenta to allow blood to flow. So it certainly has happened, not often, but it has happened that blood doesn't flow. And or there may be coagulation in the vessels, perhaps you've taken too long to try and collect the blood, and the blood starts coagulating, especially if the placenta is obviously already out the uterus. So there are hundreds of possible reasons why there is no blood that flows into the bag.
Okay, thank you. And the next question is, are there any ongoing studies about potential use of stem cells in treating for COVID-19 patients?
Yes, there are. There are actually quite a few studies. So COVID-19 is a viral disease, as you know, and causes severe inflammation, particularly in the lungs. Now, mesenchymal stem cells that we actually get from the cord tissue are have great anti-inflammatory properties, and they can modulate inflammation quite well. However, COVID-19, it's such massive inflammation that happens very acutely and kills the patient quite quickly, that stem cells at this point, by the time you infuse stem cells, they're not really going to help much. I think certainly the drugs, the anti-inflammatory drugs and ventilation are really more what the patient needs than the use of stem cells. But nevertheless, a lot of research is being done, so look, we never know what may come of that. But currently, there are no major answers.
Okay, and then the next question is, delayed cord clamping showed to reduce the volume, but did it show any effect on the quality of the stem cells collected?
No, not the quality. The quality of the stem cells is all the same, and it's just about number. It really is just about number. There's just a lower number if you get lower volume. So yeah, that's no, not the quality. The quality is the same. Say, immediately after birth or 30, 60 seconds, after, it's all the same cell.
Okay. Then the next question is, with extra people not being allowed into hospitals, does this raise a problem for stem cell collection?
Not as yet. So we have, we obviously speak to the parents on the phone, explain all the packaging procedures. I mean, we've been around, gosh, for 15 years now, so all the hospitals are very well aware of the whole process and are, quite confident to collect the cord blood and pack it correctly. And our drivers come to the hospital. They have to wait outside, and the hospital staff go and collect the collected stem cells and bring it out to them. So we've managed to work through with the hospitals. They have all been very cooperative. So we haven't found any problem. The only problems that we are having is with the couriers. There are times, because of the decreased flights, that we may have parcels stuck around the country that we have to try and get to our laboratory within 48 hours. So that is sometimes tricky, but our medical couriers really do try their best to sort it out. I think it will be easier once a lockdown is lifted.
Thank you, Yvonne. Next question. Does the premature baby benefit more from delayed cord clamping than a term infant?
Yes, they do. They most certainly do. They need, as I described, all the benefits for their cardiovascular system, their iron stores, protection against intraventricular hemorrhages. Your preemies definitely benefit. I wouldn't, term infant is stronger and less at risk to having all those other problems that a preemie has. And delayed cord clamping just gives the preemies a better chance. And that is why the pediatricians are very passionate about that. Any more questions?
Yes. So then the next one is, can Netcell send someone to do the collection if the doctor or midwife cannot do it themselves?
That is difficult. If I say yes, that is possible in Johannesburg or Pretoria, because our offices are there, and I'm at that office, and my other medical officer and we're very willing to come out. Obviously, it is such as Cape Town, PE, Durban. We have our consultants, but they are not nurses. They're not medically trained, so they can advise you, and they've all been shown how to do it. And I'm very happy to talk through the procedure with the doctor or midwife, but we don't have medical people in those places to assist, unfortunately.
Okay, next question. When the patient is said to have recovered from the COVID-19 infection, what does this exactly mean? I think this is with relation to your previous question that you had about if stem cells can be used to help treat the patient.
So recovery from COVID is essentially a recovery from symptoms that your breathing has returned to normal, that you have stopped coughing, that you have no other signs of infection such as deranged blood results and fever. And that is when a patient would be deemed as recovered from COVID. They may not necessarily be completely virus-free. They have shown that patients that have recovered often are shedding virus well into like a month after they have recovered. So that hasn't been a good indicator, but essentially a patient is recovered if they have returned back to normal.
And then we've got another question. Yes, from a doctor who I think is an international doctor. We had a hitch sending our samples with flights on hold for now, as it's become easier for international. Has it become easier for international collections to go through and reach our lab? Sorry.
So at the moment, I think certainly from Africa and I know in Kenya we had a problem on the weekend because there are only a few British Airways flights that are flying out and down to South Africa. At this point in time, it's almost like on a day-to-day basis. They decide if they are going to fly out or not, if they have enough cargo or not. So that is what is so difficult for us. You know, we work with DHL, we work with FedEx. They're the biggest in the world, and even they are struggling to. If the cargo plane, if it is not full, they just refuse to fly it out, and then we have to wait until the next day. So unfortunately, we are still not able to guarantee transport 100%. And it will obviously also depend on the lockdown in those countries when that is lifted. I think once South African lockdown is lifted, more planes will be able to fly in, but it also then depends on, you know, Namibian, Zimbabwean, Kenyan, Tanzanian lockdown and how they are going and if they will allow planes out.
Great. Then the next question is, can extended delayed cord clamping result in gingivitis in newborn babies? If so, how do home births prepare for this?
Sorry, Aline, they cause what?
How do home births prepare for this? Do you need me to repeat the whole question? Can extended delayed cord clamping result in gingivitis in newborn babies?
Maybe in jaundice, is that what they mean?
Yes, yes.
So the jaundice. So yes, delayed cord clamping can result in jaundice. That is polycythemia. And particularly in your term babies more, your bigger babies, and if they get you know, extra blood, it can result in that. I don't think it happens every time. It does depend on the child, the weight, the amount of blood that was in the cord blood. So I think with medicine, as in life, everything within reason. And if you're doing a home birth and say you're not collecting stem cells, you know, I think you could do easily 2 to 3 minutes of delayed cord clamping, and the baby should be fine. And you know, then you can clamp the cord and deliver the placenta. But then the bottom line is, and I think what the pediatricians are trying to say is, just take a little bit of time. Don't be too quick to just cut that cord straight away. Allow some of the umbilical cord blood and placental blood to go into the baby.
And then we've got one last question. How long can you store stem cells for?
So we have documented proof that stem cells can be stored for 24 years. Theoretically, they should be able to be stored for much, much longer than that. But that is the study that was done by the New York Blood Bank, where they have stored stem cells for 24 years, stored them, and checked on their, obviously, viability and functionality, and that was proven to be absolutely fine. So you really can store them for easily for 24 years, if not longer.
Okay, sorry, we've got another question. I'm assuming that clients obviously are asking the doctors, you know, what kind of price, what is the pricing? So I'm happy to answer that. You know, clients are always more than welcome to pop onto our website. We've got an amazing pricing calculator, which is really easy to use, and we're very transparent with our pricing, so they can go on there. And then another question is, where can doctors find more scientific data in terms of delayed cord clamping and stem cell collection, Yvonne?
Well, I can certainly share these articles with you. Perhaps you're welcome to email us in answer to this webinar, or even Ali, perhaps when we share with all the attendees a recording of this webinar, we can attach the articles to that.
Yes, I will definitely. They'll definitely get a
possible?
recording, and then I'll attach the webinar, the articles as well.
Yes, because those are really as scientific as we can get, and there aren't too many articles on that, but these two that I presented today are probably the best.
Okay, thank you. I think that's all. We don't have any more questions.
Lovely. Thank you everyone. And should you think of any more questions, please feel free to contact us either via our website or email us directly. Thank you.